Colorectal cancer, cancer of the colon and rectum, is one of the most common cancers, and one of the leading causes of cancer death. But it has a remarkable feature that sets it apart: it's one of the few cancers we can often prevent entirely, by finding and removing its precursor before it ever becomes cancer. That single fact makes it one of the most important cancers to understand. The key to colorectal cancer is understanding how it develops, because that's what makes it preventable. Most of these cancers begin as a polyp, a small, initially harmless growth on the inner lining of the bowel. Over a span of years, and through a well-understood sequence of mutations, some polyps gradually turn cancerous. That's the crucial detail: the process is slow, and it's predictable. There's a long window, often a decade, between a benign polyp appearing and it becoming a dangerous cancer. And a slow, visible, predictable precursor is exactly the opening that a good screening program can exploit. This is why colorectal screening is special. Most cancer screening only detects cancer earlier. Colonoscopy can actually prevent it. During a colonoscopy, a doctor guides a flexible camera through the colon and inspects the entire lining, and if they spot a polyp, they can remove it right then and there, before it ever has the chance to become cancer. That's prevention, not just detection. There are also simpler, less invasive options: stool-based tests done at home that check for hidden blood or for cancer DNA shed into the stool. Those are easier to do, and if one comes back positive, it's followed up with a colonoscopy. The message from doctors is blunt: getting screened on schedule is one of the most effective cancer prevention steps that exists. When colorectal cancer is actually found, the cornerstone of treatment is surgery, removing the affected segment of the bowel and reconnecting the healthy ends. Caught early, before it has spread, that surgery alone is often curative, which is another reason early detection matters so much. If the cancer has reached the nearby lymph nodes or grown deeper into the bowel wall, chemotherapy is usually added after surgery, that adjuvant approach we talked about, to kill any microscopic cells left behind and cut the risk of the cancer coming back. For rectal cancer specifically, radiation often joins the plan as well, because of the tighter space it sits in. For colorectal cancer that has spread, treatment gets more personalized, and it echoes the precision medicine theme running through this series. The tumor is tested for specific markers. Mutations in a gene family called RAS, for instance, determine whether a certain class of targeted antibody drugs will work. If the RAS gene is mutated, those particular drugs won't help, so testing prevents wasted treatment. Other drugs block the tumor's blood supply. And there's a standout subset: cancers with a feature called MSI-high, meaning they carry a specific DNA repair defect. These tumors turn out to respond remarkably well to immunotherapy, a striking result that helped prove immunotherapy could work in a cancer well beyond melanoma and lung. The takeaway for colorectal cancer is genuinely empowering. Here is a common, deadly cancer that is highly treatable when caught early, and often preventable altogether, because we can find and remove its precursor. One worrying trend worth knowing: colorectal cancer has been rising in younger adults, for reasons researchers are still working out, and that's why screening guidelines in many places now start at a younger age than they used to. So if you're of screening age, or you have a family history, or you have persistent symptoms, this is the cancer where acting early has an outsized payoff. As always, this is educational, not medical advice. Talk to your doctor about when your screening should begin.